Today on The Question Is with Anthony Portantino, we will hear from two leaders in the field of women's health cancer risks, diagnosis, and treatment. Good friends and very accomplished healers. Today we're going to discuss the controversy over mammograms and who should get them, when they should start. We're also going to talk about breast cancer risk factors, the BRCA2 gene, just to name one, and we're going to get to the bottom of the HPV vaccine and its impact on cervical cancer, and you'd be surprised, young boys as well. Let's ask the question. I'm Anthony Portantino, and welcome to The Question Is. I'm very honored to be joined by Dr. Alexandra Levine, who is the Chief Medical Officer of the incredible research hospital City of Hope, a distinguished professor of medicine at USC and a renowned researcher in HIV and AIDS, having worked in the past with Dr. Jonas Salk. I'm also very honored to be joined by Dr. Laura Sirott, a leading gynecologist at the Great Huntington Hospital. She is also the chair of District 9 of the American Congress of Obstetricians and Gynecologists, and she serves as the chair of the Legislative Committee working positively to affect healthcare policy in California. Yes, we'll be walking through mammograms, breast cancer, HPV vaccinations, and cervical cancer. You won't want to miss this, so let's get right to the question. Doctors, tell us about mammograms. There's a big controversy in the news every day about when should a woman be getting them, when shouldn't be. Please walk us through that.
In my practice, I recommend routine screening starting at 40. With
40.
annual mammograms every year thereafter.
So you don't see the controversy of that age isn't the primary risk factor. You just think that we should continue regardless of what those other risk factors are?
Those other risk factors I think will affect the age, but the overall where to start would be 40, and then you might personalize it for those individuals who have those factors.
It is controversial, and I would agree, by the way, as far as my own thoughts, but the guidelines are different in the United States. The suggestions and the concepts of what we should do. So the American Society of Clinical Oncology, as an example, says that the age should be 40 years to start, and that mammograms should be repeated once a year. That has been the standard in the United States since 2002. Recently, the U.S. Preventive Health Task Force came up with new recommendations saying that this screening should occur starting at age 50 and should be perhaps every 2 years and not every 1 year. And that became very, very controversial in the academic community and the clinicians as well. So there is a controversy, but luckily we agree.
Now, we also see that there are women obviously younger than 40 who develop breast cancer, and a lot of that can be contributed or attributed to the risk factors. Obviously the BRCA1 and the BRCA2 gene. That's relatively recent that we've isolated that gene. How does that factor into younger women when we have a 25-year-old patient that has that mutation in their system? How do you find out, and what happens at that point?
If they have those significant risk factors like a BRCA gene, then they should be tested earlier with ultrasound, self-exam. Many of the younger women are finding their breast cancers themselves on physical examination before any testing would be started. And you just have to have a little bit lower threshold for doing those diagnostic tests.
Well, one of the problems with doing mammograms in younger women is that the breasts are quite dense in younger women and get less so, more fat in there as you get older. And it's harder to actually see something. It's harder to diagnose, and easier to say that something looks suspicious and needs a biopsy when it really is nothing, when it's benign. So there's an increased risk of having a, quote, false positive mammogram, i.e., the mammographer says there may be something there and a whole workup occurs, and that something is really nothing. It's just normal breast tissue.
Now, is that changing with the use of digital mammography? Is there a different result with the traditional mammography versus the digital machines, or is it the same issue regardless?
I think the digital has become the standard of care now.
Okay.
It's just how it's interpreted. Instead of a film, it's done on the computer so they can see it better.
So most hospitals today are equipped with the digital mammography.
I believe so.
Yeah, I would think so too. But you know, sometimes you do have to use other techniques, MRI scans as an example, ultrasounds as an example, to try to sort out whether that normal dense breast tissue is just normal or whether there might be a tumor hidden underneath. And so the controversy, a good deal of it, is related to the difficulty, perhaps, of diagnosing appropriately whether something is normal breast tissue or a cancer in a young woman, 40 or less.
Obviously, with your patients, getting to know their family history is critical in when you have a new patient, when you're tracking a new patient.
Correct.
I mean, I saw somewhere that if you have a close family member who has had breast cancer, your potential to have breast cancer increases by 50%.
If there's a first degree
First
relative
degree.
and any of the other risk factors, but that breast density is, the way I explain to my patients, it's as if you're looking out the window and you've got a screen on there. If you've got blackout drapes, hence dense breasts, you're not going to see through to what's hiding behind it. If you've got sheer drapes, you'll see through. So as their breasts mature, you can see through it better. So then you need to use those other tests, the MRIs and the ultrasounds, more to screen those tests.
Now we
Those
see
abnormalities.
with older women, or I guess women over 55, more Caucasian women are developing breast cancer in that segment and than African American women and other ethnic minorities. But the treatment option, not treatment options, how do I say it? The prognosis is different based on certain socioeconomic factors. So we're still seeing a big disparity in healthcare coverage and healthcare diagnosis with women of color. Would that?
Yeah, I would agree. So the question was whether there was a scientific reason, a biologic reason, why African American women would do less well with breast cancer than other groups. But in fact, there's no real biology. It's just access to care.
Access to care.
And it's another example of why mammography is important, and you can diagnose a case very early and save a life in that way. It's said that mammography saves about 20% of the lives of women with breast cancer because it's diagnosed very early by the mammographer. If you don't have that available to you, by the time the patient comes in, it's already more extensive disease, more difficult to treat, and the prognosis won't be as good.
And so that's why we see such an effort put on bringing even remote mammogram testing facilities into communities to try to get more and more women diagnosed early.
Exactly.
Turning to the prognosis, because we do know once we discover the existence of breast cancer, our survival rates today are much different than they were 20 years ago.
Without any question. And that's even true in the women who have the abnormal gene, that BRCA BRCA1 or BRCA2. The vast majority of breast cancers in women are not genetically determined, are not related to BCRA1 or 2. On the other hand, those women who are affected will know it theoretically because of a family history, and as was just stated, a first-degree relative. That means a mother, a sister, somebody very close to you genetically had breast cancer very often at an early age, or not just in one breast, but in both breasts. So there are some clues that somebody might know to get tested. The women with BRCA1 and 2 are clearly at increased risk for breast cancer and need early mammograms and other techniques. On the other hand, once they get breast cancer, they do just as well as other women. So it's not a bad prognostic sign, it's just a risk factor for getting it. The same genes are also associated with development of ovarian cancer. And so these women need very, very careful attention. All kinds of things are done to prevent both of those cancers.
And is it a blood test that tests for the gene?
Yes.
So, and is that becoming part of routine health screening to do the blood test, or no?
It can also be done on saliva.
Saliva.
Or
So what
buccal swab.
percentage of women are being, do we have a ballpark, are actually being tested for the existence of the BRCA1, BRCA2, or is that something they request themselves? How do we make it more a part of routine health screening?
Well, they oftentimes will come in and request it, but it's very frequently denied by insurance carriers because they need to have a proven BRCA person affiliated. So let's say their mother was diagnosed with an early breast cancer, she's since passed away, and they can't prove that she was a BRCA gene positive. So then her daughter comes in worried about her risk, wants to be tested, and it's denied. It's a very expensive test.
Interesting.
And I would say also, so that's a good example of a controversial area where, let's say a mother died at a young age of breast cancer, you're going to think right away, maybe that is BRCA1, and that person really should be tested. But in answer to your question, should this be part of routine medical care in women in the United States? No, no. It's very expensive. There are, you know clinically that somebody is at a risk. What is that family history to start with? And so it really, I would not be advocating that every woman should have BRCA1 testing. Not necessary, actually.
But those who warrant it should have an easier path to get it.
Absolutely.
And it does not change their path through treatment, it changes their family members.
Right.
With the exception of if they're BRCA positive, it would affect their ovarian, their risk for the ovarian cancer and whether you would do ovarian preservation or have an early oophorectomy, removal of the ovaries to protect them from that cancer risk.
Okay.
Sometimes what happens in that setting of BRCA1 or 2 positive, the woman may choose to have prophylactic to prevent bilateral mastectomies. And that clearly will decrease the risk. It doesn't go down to 0, but it clearly decreases the risk. As the woman ages, another thing that can be done is removing the ovaries, as was said. And usually what happens is that decision is delayed a little bit until the woman has had the children that she wishes to have or reaches menopause or close to menopause. So there's a timing issue of when things could or should be done as well.
There are risk factors that can be controlled, and there are risk factors, obviously BRCA1, BRCA2 can't, but you either have it or you don't. Obviously the risk factors that can be controlled are pretty, my doctor tells me exercise, eat right, and do all the good things. I mean, those are typically things you would tell your patients as well. Don't smoke, eat right, exercise, right?
Mm-hmm. Everything in moderation.
Everything in moderation.
But it's kind of interesting because the female hormone estrogen is a growth factor for breast cancer cells. It's a car needs a gasoline to drive. Cancer cells need growth factors, needs chemicals to allow them to grow. Estrogen is a growth factor. And it turns out that fat cells are rich in estrogen. And simply by having fat cells, the milieu, the setting is appropriate to allow a breast cancer cell to start really to grow and divide and become a clinical illness as opposed to one single cell.
So we see that certain practices we should certainly encourage. Obviously, routine visits to their healthcare professionals is important. Certainly we see with the greater community, we want to make sure that folks have access to early detection. And then we also see the good news is with that early detection, prognosis and healthy lives from that point on, the advances have gotten to be so great.
So encouraging well women checks, having their physician check their breasts, have them check their own breasts, have their annual mammogram, and that's the best they can do for routine screening.
So we should tell women to tell everybody, men, women, people like myself, eat right, do well, go to your doctor and listen to what they have to say and see the wonderful advances that are having in detection and in treatment. When we come back on The Question Is, we're going to talk about the HPV vaccine, and you'd be surprised the number of young gentlemen who are also getting it these days, and we're going to delve into that controversy and how it affects cervical cancer when we come back on The Question Is.
Who needs this modern world? I can live just fine out here without the road rage and boy bands. Of course, I might miss my Charter HD with football on ESPN and Walking Dead on AMC. ESPN and AMC. And, well, Shark Week on Discovery HD, but that's all. AMC, ESPN, Discovery, TBS, and Comedy Central HD. But that's it. Except for HBO HD.
Charter now has over 100 HD channels and more brilliant HD shows on demand than ever.
We're back on The Question Is with the Chief Medical Officer of City of Hope Hospital and the Secretary for California's ACOG. Tell us about HPV. What is HPV anyway?
HPV stands for human papillomavirus. And this virus has many types, maybe 100 different types. Some of them are clearly the cause of cancer. And HPV can cause many cancers. It causes cervical cancer of the cervix in women. It causes penis cancer in men. It causes anal cancer in both genders. It also is known recently to cause head and neck cancer. This is clearly a very, very difficult virus. And luckily for us, there is now a vaccine against being infected with that virus. But again, it causes many different cancers in both men and in women.
And so the vaccine, 3 shots over 6 months, and if I understand it, 70% of the cancers that were previously attributed to HPV can be eradicated.
The data is showing just that. The issue really is that the uptake of that vaccine has simply not been adequate enough. And why people are afraid, I am not.
So what's the controversy?
It's a vaccine. A lot of vaccines have controversy. They're feared for the unknown. It's relatively new. It's only been out about 6 or 7 years. And I think a lot of people fear that it's got consequences we haven't yet discovered.
Right.
On
And
the
there's
other
no data
hand,
to support that.
Correct.
No, there's no data at all to support it, nor is there data to support that measles, mumps, chickenpox, and the other vaccines are in any sense associated with autism or anything else that has been described. So this is a false fear that is creating real difficulties in the United States without any question at all. I think one of the other controversies of the HPV vaccine is that some people believe that if they allow their children to be vaccinated, they will become sexually active because of that. And that also makes very little sense to me.
Well, I can tell you just this week, I took my 11-year-old daughter to the pediatrician to have her second vaccination. She had no idea what we were doing other than she was getting a shot, and she wanted some ice cream after she got the shot because her shoulder hurt for a little while, but she was quite brave in that room. I actually hurt me more than it hurt her because I was holding her hand, but she just knew she was getting a shot to help her down the road, and it had no, social or sexual implications at all.
And I had my son vaccinated at the age of 14, just before it was approved for use in boys. And when asked why was he getting it, he told his doctor because it will prevent anal and oral cancers in men. So he was properly brainwashed into the right.
That's what happens when your mother's a doctor. You know these
Right,
things.
you do the right thing.
Notice
You
I
do the
haven't
right
used
thing.
any of those words. I've been avoiding all the technical words and leaving them up to the doctors here.
But you said something that was important to me. We don't, to our children, we don't say, you're getting a chickenpox vaccine. Let me explain all of chickenpox to you. You go to the doctor, you get the vaccines.
Right.
And again, to think that this has anything to do with augmenting the opportunity for sexual activity is not valid.
And the key piece of the sexual activity part is that's how the virus is transmitted through sexual activity. So
Absolutely
you want to
true.
get vaccinated when your children are
Sexually naive. is
sexually
the-
naive. I mean, it just makes perfect sense, and I'm so glad you talked about your son because this isn't a virus that affects one gender over another, and we just have to deal with it. And to me, you have the ability to eradicate 70% of type of cancer. Take it.
And again, many cancers. I don't even know how to say this strongly enough to the audience. You don't want cervical cancer. It's a horrible cancer to have. You don't want it. And you really don't want anus cancer either. I'll say it because she's a public person and she helped a great deal, but Farrah Fawcett suffered a great deal. Anus cancer occurs in men and in women. HPV is more likely to be in the anal region in women than it is in men. If it gets into the cervix, it goes into that entire area. And now head and neck cancer. No, these are no joke in any sense at all. They're not easy to to have, they aren't easy to treat, they're easy to die from, and they're easy to die from in a very painful and unpleasant way.
And science has given us an ability to deal with 70% of them. We should be taking them. Talk us through cervical cancer, you know, general patient health. How do you deal with your patients on that road, for lack of a better expression?
So the current screening for young women is to start pap smear screening at the age of 21. And we've moved that up from any time, like 17, 18, whenever they were coming in, because we know that the virus can be eradicated by your own immune system. So we start at 21, and annual pap smears are recommended, and we don't actively treat some of the early abnormals like we did in the past, and that's because these treatments have their consequences and can affect fertility and costs and treatment and emotional distress. And then we screen every year in the 30s and up. It's now recommended that the pap smears be obtained once every 1 to 3 years, depending on their history, and should have co-testing, so the HPV virus screened at that time.
Since HPV causes cervical cancer, the concept is that if an individual is HPV negative, is not infected, she will have less likelihood, to put it mildly, of ever getting cervical cancer, and therefore the pap smear doesn't have to be done every year. It could be done every 3 years if somebody is HPV negative. If somebody is HPV positive, then that pap smear should be done more regularly. But the concept of the pap smear was very, very early diagnosis before the cancer begins. And what happens is the virus infects the cells of the cervix or anus or mouth, if we're talking about that. And it takes a number of years for the virus to slowly change from just a viral infection to early pre-cancer. Not cancer at all, but it's going to be if you leave it alone. The pap smear shows those various phases of pre-cancer, something called CIN1, and then that may go away, but then CIN2, and that progresses to CIN3, and that progresses to cervical cancer. And so, for example, if the gynecologist does a pap smear and sees CIN2, that can be treated, and it will completely prevent that woman from that lesion going on to cervical cancer. That's what the pap smear did.
But it should be really clear that just because someone has HPV does not mean that they're going to get cervical cancer. It's still a very small number of women who will actually progress to that. And we have a number of ways of diagnosing and treating that early pre-cancer type situation before it ever becomes anything bad.
Right. And again, the key is get the vaccine when you can.
Prevention, early diagnosis,
and good habits, general health habits on top of all of that.
Right. Cervix cancer used to be the most common cancer cause of death in women in this country, and it still is. For example, in India and in other countries in the world where pap smears are not done or HPV vaccines are not available. So this has gone from the most common cancer to the least common cancer in women.
Now, you talked about when you're HPV positive, and that positive comes out of the pap smear, or does that come out of a blood test, or how does one find out if they're HPV positive?
It's tested at the time of pap smear. So when the pap smear is obtained, the cells that are obtained at the time of that brushing of the cervix, they can run special testing on that for the virus, and they can then distinguish between the strains of the virus, whether it's a low risk, which really doesn't carry any of these risks. Those are going to be more associated with venereal warts or condyloma, or the high-risk strains. And the two most common high-risk virus strains, 16 and 18, are what is in the two currently available vaccines.
Now, how about for men? How does a man find out that he's HPV positive?
This could be a blood test as well. This is also done through, quote, anoscopy and looking at the anal cells. HIV-infected men are more affected than HIV uninfected. Gay men are more involved simply because of anal sex, and the ability to spread that virus, again, sexually, but into one area versus another.
Right.
But it's not something they can see. So they don't know that they have it.
Right.
And they can't tell that they're spreading it. And so what the vaccine is doing is stopping the vector. If you vaccinate the men, they can't infect the women. The women are the ones who are the victims of it.
Right.
So in order to completely eradicate it, we have to vaccinate everyone.
Right. And so that's another piece of the puzzle is we're doing a better job seeing 11 and 12-year-olds getting the vaccine. How are we doing with 22-year-olds?
The issue is that once you start dealing with 22-year-olds or 32-year-olds, chance is highly likely that they've already been sexually active and they may already be infected by HPV. And if they are already infected, then the vaccine won't work to prevent that infection. It's already there. On the other hand, if an individual doesn't know, I personally would be getting that vaccine. And it's, you are completely correct. It will prevent spread of a virus to a female sexual partner. But the other issue is there is a significant epidemic in this country right now of anal cancer in men and in women. And it's hard to diagnose that early in men. You can't unless you know about it and get the equivalent of an anal pap smear. That's being done. And there are large studies in the United States to look at the same progression of anal cancer as occurs in cervical cancer. Starts very simply with an infection, may go on to pre-cancer in the anal region, and then finally full-blown cancer. Can you prevent the full-blown cancer in the anus by eradication, by cutting that little area out or burning it or freezing it? Will that work? We believe that it will, but it's never been proven yet.
Wow.
And just not having anal cancer does not prevent it. So it can be transmitted without the anal penetration.
It's called a field effect. And so if a woman is infected by HPV in the cervical secretions there, the virus kind of travels in that whole area, and the anus is right there as well. So the HPV can cause vaginal cancer and labial cancer and anal cancer. That whole field, that whole area is involved.
What fascinates me is we spend so much of the media's time talking about the shot, and it's a much more deep, involved conversation that just doesn't get out and see the light of day.
Part of it is it's hard. Here we are on television talking about anal cancer. I'm impressed that you're willing to educate the population, because that's what we need.
We'll see what my posts are on Facebook when this show airs and what people have to say. But I think, you're right. It's a very, very important conversation because we have the vaccine. The fact that we don't use it to its full potential, shame on us. And obviously there's a number of issues that we see, and you and I have talked about HIV testing and why that should be more routine, because we can stop the spread. This has been a fascinating conversation, and hopefully we've educated both moms and dads about, get the 3 shots. Nothing bad's going to happen from getting the 3 shots. Do it and cut down 70% of cervical cancer risk, because as you've said, it's something you just don't want to deal with. And obviously, you've had patients that you've helped through this as well. So thank you very much for being on The Question Is with Anthony Portantino, and I hope you enjoyed this very dynamic conversation with 2 incredible healers. Thank you.